Okay. So who want to volunteer?
Me, doctor.
Okay.
Okay. The first there's old man is drooling of saliva. So the problem there is a unilateral facial weakness over the right side. And,
Good.
um,
Okay.
and
So what is the description in the photo?
the description loss of nasolabial fold, and then the forehead there is no losing of the forehead wrinkle, and then the eyebrow inability to
Raise
the
the eyebrow. Okay.
raise
So all of this show that this patient has weakness over the right sided of the face. You can say that the upper part and lower part of the face kan. So if the problem you said right sided facial weakness as described in the photos. And the description is what you told lah kan. So you year 5 ke year 3 sorry?
year 5.
Okay. List 5 causes. So sekarang ni you tak jawab lagi tau. Identify the problem tu right-sided facial weakness secondary to
Secondary to it could be secondary to lower motor neuron lesion
good lower motor of
or belt or
Vision lah.
siapa nak jawab yang tepat? Dia tak payah panjang-panjang. Apa masalah dia ni?
belt palsy.
No, that is etiology. You tak jawab lagi apa problem dia. Right lower motor neuron facial nerve. Palsy. Okay, facial nerve is 7 nerve palsy.
Okay.
It's not facial weakness, it's the manifestation. But the localization is low motor neuron 7 nerve. Okay, so list 5 etiology.
First is belt palsy and Ramsey-Hunt syndrome, and also otitis media infection, and postparotid gland surgery.
Surgery, okay. OCPA angle tumor and anything. So explain the localization. Do you know the localization? Where is the 7 nerve cause?
Is it at the so basically this lesion is about lower motor neuron. So
so why this patient have involvement of the both upper and lower part of the face? What is the difference if upper motor 7 nerve and lower motor 7 nerve? Anyone would like to answer?
is it the forehead? The sparing of the forehead.
I know that is the difference, but your friend want to know why you said this is lower motor. What is the in terms of neuroanatomy? How you explain this?
Doctor, can I try to answer?
You can answer.
So for the upper motor neuron lesion, there is usually sparing of the wrinkle of the forehead because the lesion of the upper motor neuron lesion it occurs before the cranial nerve from the cranial nerve from the cerebral cortex they decorticates with the through the facial nerve nucleus.
Oh, actually no, that's not the answer. You can still have the lesion at one side of the cortical and motor cortex of supplying 7 nerve and facial nerve. But then why can't you have involvement of the forehead?
because they macam mana nak cakap dia the track tu dia cross.
Dia sebenarnya bilaterally involved. Bilaterally supply. This right-sided of this forehead are supplied by left and right-sided of the cortical. So kita panggil bilateral cortical supply. So kalau satu cortical damage in upper motor, dia tak akan kena. Dia still spare. Faham?
Okay, faham.
Faham tak? So, the answer is bilateral. You sepatutnya tahu ni masa you second year, tahu tak? You ada belajar pasal seven nerve ni. Tahu tak? Tak tahu
Pernah. Tahu doktor.
So, you all kena tahulah benda ni basic. Saya suka mewarna. Jadi, mari kita mewarna. So, this is the cortical yang saya maksudkan. Presentation. Dia sign kat sini. Ini belah kiri of the cortex. Ini belah kanan. So, dia pun ada dua. Dua-dua ni bagi informasi. And synapse dekat sini. So, mereka betul kan warna dia? Supply the above part. Nampak tak? Nampak tak?
Nampak doktor.
Jadi kalau berlaku lesion, let's say, dekat sini, kita cut, ni masih ada informasi di sini. So, ni still okay. Faham tak? Sebab the right-sided boleh bagi informasi untuk mengerutkan dahi. So, this is what we call frontal sparing in upper motor neuron lesion. Faham ke tidak ni? Kalau ada masalah di belah kiri, belah kanan masih normal untuk give the supply. Faham? Siapa yang tak faham lagi? Hello?
Faham
Faham?
doktor.
Siapa tak faham tu memang benar lah. Benda basic saja. Kiri dengan kanan bergabung menjadi satu dan supply the forehead. If you have stroke at this cortical area, either left or right, you tak akan stroke dua-dua belah. You stroke sebelah saja. And sebelah lagi masih ada intact. That's why we call forehead sparing, which means forehead are not involved for the upper motor 7 nerve. Get it? Faham However, yang bawah ni are the presentation yang memang daripada nuklei ni. So macam mana pun dia akan kena. Sebab the lesion kalau kat sini pun dia tetap akan kena. So ia akan ada lower motor 7 nerve. Sebab yang hitam ni hanya disupply daripada sini. Faham Faham tak? Boleh gitu pula.
Faham doktor.
Kalau you faham dia bentuk gambar rajah ni lah. Okay. So the lower part ni akan supply by the contralateral part only. Dia bukan dia double representation, double supply. Okay. So let's say satu lagi yang ni lower motor. Sekarang kita warnakan dia warna merah. Ni upper motor ni warna hitam ni. Okay. Ni warna ni. Okay. So yang ni go down, supply yang upper part. Okay. Sekarang isu dia bukan di situ. Isu dia sekarang kita ambil warna biru. Kita ambil yang bawah ni. Yang bawah ni dia turun ke sini, sampai sini. Dan dia supply ke sini. Alah, dia tak boleh nak ni. Okay. Erase je. Erase. Okay. Okay. So, kalau ada lesion, okay, ada lesion dekat sini, So you akan dapat sini dan sini. Faham tak?
Faham doktor.
Maknanya apa saja dekat sini, dia akan cut dua-dua. Merah kena, biru pun kena. Faham tak? Sebab memang itu je track dia. Dah tak ada jalan dah lagi. Faham? Okey. Tapi kalau yang hijau ni, kalau you dekat atas awak potong, yang belah kanan tu masih ada lagi jalan macam biasa, yang bawah still intact. I hope you understand So that's why in lesion of lower motor, apa definisi lower motor? Okay, lower motor. Okay, you all semua cream of the cream. Maksudnya you all ni bukannya dah jadi doktor sebab kabel tau. Dia macam kena pandai baru boleh jadi doktor. So kalau susah sangat nak faham tu maknanya something wrong lah tu. Sebab this is about wiring, like electrical, like engineering ataupun whatever. You need a brain, an IQ in order to understand. And so this, let's say lah kan, lesion dekat yang ni, so dua-dua track kena, so that's why the whole face on the similar side akan affected. So apa maksud apa motor, apa maksud low motor? Any lesion daripada sini sampai sini adalah apa motor neuron. Apa motor neuron. Okay? Lesion daripada bawah atau disebabkan oleh apa-apa sahaja. Daripada bawah nuklei ni sampai ke bawah, apa-apa sajalah yang kawan nak sebut tadi, kita panggil low motor. Faham ke tidak? Hello, faham ke tidak?
Faham.
Siapa yang tak faham boleh tak bagi tahu saya kenapa you tak faham? Siapa yang tak faham? Cakap doktor saya tak faham. Cepat. Hello. Ada orang yang tak faham tak? Betul semua faham? Betul confirm kalau tak faham cakap dia, tak apa, cakap saya memang benar doktor, boleh bagi tahu saya tak? Saya tak faham-faham. Siapa yang tak faham? Okey, confident you all semua faham kalau tak you ambil ni nanti you warnakan. You warnakan. Okay, ni macam gitu. Ni macam gini. Macam gini. Ni supply dia. Yang ni pula low motor. Macam ni, macam ni, macam ni, macam ni, macam ni, macam ni. So kalau lesion dekat atas, dia akan cut you agak-agak. Yang ni akan supply, yang ni akan intact. Masih boleh normal lagi. Yang merah dah kena dah. So merah akan kena bawah saja kena. Ni kalau apa motor. Tapi kalau lesion dekat bawah sini cut, dua-dua kena. So separuh muka mesti kena punya. Dah 3 kali dah saya sebut benda yang sama. Ulang. So jawapan dia adalah bilateral cortical supply of the forehead in the right side and left side of cortical supply. Therefore, in patient with upper motor neuron lesion, such as stroke case, they will spare the forehead. Okay, that's the answer. So how about seven nerve? Okay, seven nerve ada macam-macam jenis diagram yang gambar raja di Google yang mana you boleh faham. Ini adalah nak menunjukkan bahawa this is the brain cortical, which is this area. So and then you go to the pontine. Here is a pontine, okay, which is nuclear lesion. So in the nuclear lesion, there are many seven nerve ni ada banyak nucleus yang bergabung menjadi seven nerve lah. So this is how dia ada branch dia lah, greater petrosal and palatine ganglion sampai the lacrimal gland. Dia go to lubang dekat telinga tu, internal meatus. Okay, and then dia go macam gitu. Lepas tu dia go down. Yang ini stapedial, dia dampen untuk mengurangkan kebisingan dalam telefon. Kalau orang telefon kita tak rasa kuat sangat. So stapedial and then chordae tympani untuk lidah. Okay, deri rasa juga. And then stylomastoid foramen, and this is parotid gland and pergi ke muscle. Ni yang kawan you kata kalau parotid surgery boleh cut. Okay, any lesion macam contohnya dekat internal acoustic meatus, tempat lubang telinga yang nak masuk ke brain tu, the otitis media ke infection of the ear canal boleh kena pregnancy can cause edema and compress, and then lesion dekat pontine sini sebab ada cancer because of the pontine glioma ke ataupun CPA angle tumor in between this two angle they also can cause. So this is the some of the course, and this you learn this in year 2 block 4, so you should go and take the notes and read again. Okay, now I give you 5 minutes, not 5 minutes, maybe 2 minutes only, just to digest what is the story and the photo, and then I will ask you more questions. Hello ya. Salam. Uh-uh. Uh-uh. Saya set line. Yang satu lagi, dah approve ke? Belum kan? Saya nak tunggu satu lagi Chinese patient. Dah sampai dah? Oh, pelik pula ah. Tak apalah. Okay. Okay. So, siapa nak volunteer?
Can I try, doctor?
Okay. What is your name?
My name is Putri.
Okay, Putri. Okay.
Um,
So, can you read?
yeah.
Okay.
45 years old lady presented with 2 weeks history of double vision.
Alright. Before that, I want to ask you, what is double vision? What is the medical term?
Diplopia?
Okay. What caused double vision, Putri?
Deviation of the
Usually we have horizontal diplopia and vertical diplopia, where you will see that the patient have side by side looking into one pen, or it's like above and below, we got vertical diplopia. So if you see patient with diplopia, what would be, you think, the pathology that can cause diplopia? What is the most common pathology?
myasthenia gravis? No.
There is a diagnosis, but before you go to the diagnosis, what is holding your eyes that make it accurately see? Yeah. What could be the possibility why the patient, anyone will get diplopia? Anyone would like to answer?
Cranial nerve.
Yes, you have fifth year. I'm supposed that you have, like more better, because last year I did 3 and third and fifth the same thing. The third year is like you all now, and the fifth year was very good. So I think you need to back up, because that's the only way you to improve yourself. You need to read a lot. So anyone would like to answer? Tak ada juga.
Doctor, I think it's because of the imbalance due to the imbalance of the strength of the oculomotor muscles.
Okay, actually your eyes are held nicely by third, fourth, and sixth. Okay, your vision are by second. So the understanding, okay, third, fourth, and sixth. Third is medial rectus, all the rectus muscle, okay, except superior oblique by fourth, which likely to cause vertical gaze, and lateral rectus by six. So any problem in terms of this cranial nerve will cause diplopia. How about the neuromuscular junction between the nerve and the muscle rectus rectus that I told you? If there is disorder in the between the nerve and the muscle, we call the junction. Like in case of myasthenia gravis, Lambert Eaton's, also it can cause diplopia. How about muscle disease? Because now you have covered nerve, neuromuscular junction, and now muscle, the rectus, or whatever. For example, in case of um, myooculopharyngeal muscular dystrophy, metonic dystrophy, even though it's metonic, it's not really, but mitochondrial diseases, and thyroid eyes, which can cause buckiness or fatty infiltration of the rectus, also can push and misalign the eyeball and lead to diplopia. Okay, so the knowledge, okay, for, what else that can cause third, fourth, and sixth? Third and fourth and sixth, like seven nerve, have upper and lower motor. Sorry. So if we don't call upper motor third nerve or lower motor third nerve like in seven nerve, but we call it as supranuclear and infranuclear. So after the brainstem, for example, like in points, we call it infranuclear. Nuclear is at the points, and above it we call supranuclear. So any lesion, like for example, you have a stroke, a cortical, also can cause diplopia if it's involved the third or whatever. Okay. So cortical presentation of the supranuclear before they synapse to the pons and then go to the affected place. So what else that can cause a midbrain lesion, for example, because we have PPRF that actually um, maintain the vertical gaze. So if you have vertical gaze palsy, you might have an issue. So this is a knowledge that you should be able to tell me quickly, okay? And like your friend said, that MG is under myasthenia gravis, it's under neuromuscular junction. So Putri, can you describe the finding on the, on the photo?
There's incomplete closure of the eyes.
What do you call that? Bilateral?
Bilateral ptosis.
Okay, you have to remember this because your unmet or whatever, OSCE, we give you the photo, you know. This is the same question. So you should be like immediate. This is bilateral ptosis. Okay? What else? Overactive of the frontalis to compensate the ptosis. Okay? And then on primary gaze, you can see the eyes are on diverted or laterally on the left. All right. So let's say I give you what further history you like to ask Putri.
Perhaps I would like to ask if the patient has a recent history of infection, underlying diabetes, mellitus.
Why? Why
I-
you want to ask underlying diabetes mellitus?
because among the conditions that are associated with myasthenia gravis are diabetes mellitus, some other conditions including connective tissue disease such as SLE, thyrotoxicosis as well. So with the history,
Okay.
I would ask
I want
is to
history.
rule out
Other
this.
than pass, other than directly go to past medical, what are more pathognomonic clinical features that you are looking for? Let's say this patient came to you to clinic.
mm, weakness or fatigue over the limb.
Okay. What
Uh-huh.
else?
Um, over the either proximal or lower limbs. Bulbar cells or key muscles. And then uh, uh,
Anyone? Anyone would like to give me the pathognomonic, the word that I want?
Uh, there is a fluctuation of weakness where it's worse
Yes.
after exercise.
Yes, diurnal fluctuation or fluctuation and worsen on evening, or you can set fatigability, you can set proximal muscle weakness on ascending the stairs, for example, or so climbing the stairs. So this is thing. This is the very like typical features. Inilah yang kita nak. Kita tak boleh bagi history yang sama dengan penyakit-penyakit lain. Kita nak yang very typical untuk MG, fluctuation. Why? Because the acetylcholinesterase, they have a acetylcholine receptor antibody, so they cannot bind, and then after repetitive exercise, there's not enough acetylcholine going to the transmission, and this cause fatigue. Okay? So, or double vision which worsen in the evening. So, this is a type of thing you ask in the history. Okay, and then how about examination? What is the expected examination finding in myasthenia gravis?
myasthenic snarl.
Okay, good. Lagi?
The head is held back,
Good.
expressionless face. And then
Especially is in Parkinson disease, not in MG.
muscle weakness after repeated exercise or
Yes.
like after repeated movement. And then
So you can say this patient might have a double vision on eye movement examination, and they would have bulbar symptoms or dysarthria. Depending if they have crisis, they can have respiratory depression, for example, proximal muscle weakness with repetitive exercise or fatigability, even on the eyes, visible diplopia. And then you can say that normal reflexes. Sometimes you can say to look for thyroid swelling because they have concomitant hyperthyroid sometimes or other autoimmune disease. So, what is a bedside test you would like to do to assess if the patient might have crisis? So you can do a force inspiratory or force vital capacity. You boleh peak flow dekat bedside untuk buat untuk tengok dia punya breathing tu worsen over times. Okay. So indeed, let's say I told you this patient have crisis. What is your understanding? When you label that this patient have crisis, any other people, you Fifia, I expect boleh jawab tau. Sepatutnya Fifia ni cepat je hari dah habis pukul 2:30. Selalunya lah sebelum-sebelum ni. Ini kes kedua pun dah 40 minit. Sebab you tak berjawab. Tak baca buku. So what do you think? Who know what is the meaning of myasthenia crisis? Tengah sibuk menggoogle, tak pernah baca.
Sorry, Doctor, can I try to answer?
Okay.
For myasthenic crisis, is characterized by severe generalized quadriparesis or life-threatening respiratory muscle weakness, which often due to a supervening infection.
Usually, myasthenia crisis are labelled by respiratory difficulties and bulbar. I kalau tengok dua ni, kalau weakness, I tak berapa. Tetapi sekiranya dia ada bulbar, where there is a bulbar low motor neuron palsy due to myasthenia, with 9, 10, 11, 12, not a cranial nerve, but more to muscle, low motor, because neuromuscular junction problems, so they cause weakness until they cannot swallow. This is a crisis. Okay, and then they can cause aspiration pneumonia, and then the second is breathing, because the patient they can stop breathing and have can die because of respiratory failure. So when I look before the patient develop this symptom, they might tell you, I have this kind of dysphagia, be it I have sense of chest discomfort or breathing difficulty. So before they come to crisis, you already anticipate and start the treatment. So can you tell me two type of treatment in patient with myasthenia crisis?
IV immunoglobulin and also plasmapheresis.
Good, excellent. We don't give steroid, okay? We give IVIG or plasma exchange. There are increasing data saying that high dose steroid in exacerbate myasthenia gravis. Therefore, we don't give steroid unless we give a low dose or step it up, okay, over time. So you need to know about myasthenia gravis. This is a very common question everywhere, forever. So muscle weakness detected, you need to give us to send for an anti-acetylcholine receptor or anti-mass, look for the level, and then you can further determine support the disease by doing single fiber EMG or RNS. Okay, that's all. And then treatment wise, if it's not crisis, you can give symptomatic treatment like anti-acetylcholinesterase, for example like pyridostigmine, or you can give steroid sparing agent like MMF, azathioprine, because it's auto antibody. So this is a case 3. I would like you to see the video. Okay, do you see the video? Do you see the video?
Yes, we see. We saw.
Okay. Who want to volunteer answer?
I think
Okay. Who is?
no.
What is your name?
My name is Najwa.
Okay, Najwa. Read it. Read it clearly.
Okay, 56-year-old man came with abnormal behavior and low-grade fever. He was later developed continuous jerking of bilateral limbs more than 1 hours.
Good.
More than 1 hour.
Uh-huh. So when you see the video just now, what is the thing that you want to describe?
We can describe is it generalized tonic-clonic movement,
Mm-hmm.
repetitive.
I agree. Mm-hmm.
We can also see some facial twitching.
Good, excellent. Your observation is good. There is facial jerky movement and then upper and lower limb clonic movement, right? So, and you can see the patient is in ICU, betul tak?
Yes.
Okay. And then apa lagi yang you nampak?
Presence of the Lucas mentioned, and he was intubated.
Lucas? Apa?
A presence of the patient is intubated.
Good. Intubated, intubated, a lot of line, Okay. So you describe something. What do you think? The description you do. Generalized tonic, chronic, facial jerk.
It is status epilepticus.
Excellent. So you know already this is status epilepticus. So status epilepticus is a phenomena of a prolonged seizure. Seizure is not by itself a disease. Dia macam anemia. It's not disease tu nama anemia, tapi there are many things, causes that lead to anemia. So in this patient with the abnormal behavior and low grade fever, Najwa, what do you think? The possible causes.
Can it be encephalitis?
Yes, that's number one. Encephalitis. Because there is fever, there is abnormal behavior, and suddenly status epilepticus. Okay, lagi nombor dua.
Electrolyte imbalance?
Excellent. Even though electrolytes are not usually due to fever kan, tapi electrolyte can cause status. Tapi it didn't actually explain abnormal behavior and low grade fever. So apa lagi yang lebih macam lebih jelas kepada abnormal behavior, low grade fever? Ada the
Meningitis?
answer. Ya, meningitis. Okay, lagi. Selalunya meningitis ni dia neck stiffness, neck rigidity. Tapi kita tak dapat dalam history lah kan. Patient dah intubated. Lagi? Lagi? Then you can jawab macam autoimmune encephalitis, macam LGI encephalitis in this age. Then you can answer electrolyte like hypoglycemia. Hypoglycemia, maybe dia ada fever, dia tak makan. Then dia develop hypoglycemia with status epilepticus. Then check gula rendah. Electrolyte imbalance pun boleh. Apa lagi? Anyone want to answer? Okay, list 5 relevant investigation.
First,
Assalamualaikum. Sorry, Doctor.
Salam.
Actually, the Google Meet meeting will end in 2 minutes. So
Oh, okay.
I will provide another link for another meeting in the chat box.
Okay. 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 So, what is the 5 relevant investigation?
so first we can do diagnostic step. This to look for if the patient is hypoglycemia. That might cause.
Betul, betul. Lagi?
And then serum electrolyte to look any electrolyte imbalance.
Correct. Lagi?
We can also do ESR and CRP.
Betul. Lagi?
ECG if the patient have any arrhythmia.
That's correct. Lagi?
CSF analysis to look for the etiology or causes of.
Betul, betul. CSF analogy to look for protein, what is the differential count, okay? Lagi?
CT brain.
Good, excellent. I think your friends covers most of the investigation. EEG, satu lagi. So, apa acute management? Let's say this is status epilepticus. You have to manage the patient how?
So we follow the ABC. First we protect the airway, and then we ensure the breathing and circulation. So make sure the patient have too large bone cannula and give oxygen supplementation. And for if acute epileptic treatment, we give IV lorazepam.
Okay. So, if it's tonic chronic, okay, for status epilepticus, the definition now have two time. Time one is likely that this seizure will prolong without stop in spontaneously, meaning that this is a time where you know that this seizure without medication it will be prolonged. So that's why you look for 5 minutes only, then you start medication. Even not before 5 minutes, then you have to start not the simple midazolam, diazepam 5 minutes, but you have to give the first line treatment like epilim, aneton, and keprap. Okay, 30-minute mean there is already long-term consequences. Okay, brain damage or anything. So for general tonic chronic, the definition of status is 5 minutes. Okay, and then for focal with impaired consciousness 10 and absence is 10. So what is viral meningitis, TB meningitis, fungal? Okay, this is the you have to take photo on this slide because you have to know this is CSF analysis that I look every time when I see patient with brain infection in order to for me to determine is it viral, TB, fungal, or bacteria. I have to look into this criteria. So is it close to bacteria? Is it close to viral? For example, if I have patient with high protein, low glucose, I will completely say this is not viral, and therefore I will stop viral like acyclovir. I don't just randomly give everybody all the treatment. So this is also algorithm for convulsive status epilepticus. I want you to take photos and please read it. Okay, you must at least read it and know that this is the management of convulsive status epilepticus. When it's come to 5 minutes, you have to start the first line and treatments, and then even though they say 20 to 40 minutes, but yet you have to start it even earlier. And then after if it's failed first line treatment, then you consider second which is intubation and giving all the anesthetic drugs. Okay, um, that's all. So what is the complication of status epilepticus? It's multisystemic complication like raised ICP, severe edema, HIE, myoglobinuria, rhabdomyolysis, respiratory failure, hypertension from edema, and then dehydration, acidosis, fractures. So let's go to last cases. Okay, we don't have more time now. So anyone would like to read? Who want to volunteer?
I would like to try that.
Okay, can you read it?
Okay, 25 years old lady presented with 3 days history of weakness of the lower limb. She has diarrhea 3 weeks ago, which recovered spontaneously after 3 days. Examination revealed power of 2/5 bilateral lower limb and 4/5 of bilateral upper limb. Reflex are generally absent and normal bowel and bladder control.
So what is the possible diagnosis, number one? And then what's the differential that you can think of?
First possible diagnosis would be Guillain-Barré syndrome.
Excellent. Apa lagi differential dia?
Other differential would be um, transverse myelitis. Can it be transverse myelitis?
Dengan
Dengan caudal equina syndrome.
actually transverse tu salah because transverse is upper motor. This is basically want to know either you know is upper or lower motor. Okay, when it mentioned power weakness, but then ada reflex absent, so it's likely is low motor. And then you want to say spinal shock ke apalah kan, ataupun hypokalemic periodic paralysis pun boleh. So in this the first diagnosis is Guillain-Barré lah. So the localization is low motor peripheral nerve rather than upper motor central nervous system, but you have to say that this is a peripheral nerve disorders. And more likely is demyelination. Okay, how do you investigate and confirm the diagnosis?
For the investigation, I would like to do a lumbar puncture to look at the CSF analysis for albumin cytologic dissociation.
Correct, good. Lagi?
And I would also like to do a nerve conduction studies
Correct. So
as a
look for the reduced
for
velocity
yes.
or either it's demyelination or axonal. What are two possible treatment?
The two possible treatment can be intravenous immunoglobulin
And
and plasma replacement therapy.
excellent. Like my MG, how you prognosticate the condition?
For the prognosis of this patient,
Uh-uh.
I think this patient has a good prognosis because the age is less than 40 years old, and she has normal control of the bowel
Oh,
and
no, no,
the
no.
bladder.
Usually GBS have normal bladder and bowel. It's not a spine problem because the bowel and bladder peripheral nerve are not affected in GBS. So this is not the prognostication. Prognostication are usually based on how severe is the nerve damage, based on the nerve conduction, for example. In axonal, they are more difficult to treat and prolong. However, the demyelination are better. And then they have rule of three, like one third better over time, one third static, one third or worse, or become quadriparesis. Okay. So last case is 55 years old chronic smoker presented with right-sided body weakness for 1 day duration. So noted after awakened. So you know it looks like a cerebral vascular accident. There is extreme hypertension, systolic and diastolic and hyperglycemia. So immediate management you have to actually secure the airway, look for the conscious level, assess the strokes ataupun NIHS score, which is the acute stroke assessment, and then look for glucose level as well. Okay, it's been there, and then you do CT scan urgent, and this is CT scan. And why you need to do CT scan? Because you're not sure if this is ischemic or hemorrhagic. So in this CT, please look at this. When you see hyper dense in CT is a blood, because we do give you CT and ask you, and most of you ask ischemic, which is wrong. Okay, none of the candidate that time can answer. This is bleed. Okay, this is bleed, and you must know this is mirror image of your eyes. So if this is on this is left, this is right. Okay, the mirror of your tangan. Okay, so this is left, this is right. So this is left. Okay, left hemorrhagic basal ganglia bleed with a right-sided hemiparesis. Secondary to hypertensive emergency. So I don't usually give acute treatment by giving antihypertension because it depends. If it's ischemic stroke, we try to reduce the VP slowly over many days, because the moment you try to reduce it significantly over short duration, this ischemic stroke worsen. But in a hypertensive bleed, you can try to reduce it within 25% within 6 hours. So, but yet not try to acutely reduce until normal, because still it have problems if you do that. So the complete already outline your management. So I think you should not be able to answer it. Okay, that's all for today. Thank you very much. All right. Any other question? Any question? So no, that's all. Okay.